Thank you, Dr. Lee. So, like Dr. Lee said, my name is Jacob Kneifl, and I'll be talking about the social determinants of managing type 2 diabetes. So I'll first start by talking about my story. Dr. Lee briefly talked about it, that I was diagnosed with type 1 diabetes in 2009, and I was 7 years old. At that time, it was a big life-changing moment that introduced me to a completely new way of living. This was not only a big step for me, but it was also for my family, and turned our whole life upside down. He did this by teaching us to manage daily routines around insulin, diet, and also activity. I would always have to give insulin after every time I ate. I would have to manage a certain diet, and then also with activity. I couldn't be like all the other kids and do specific activities, and I would have to manage that time as well. With that, I also faced physical and emotional challenges. I would be looked at differently in school sometimes, or there would be talk around how I was different. However, with all these challenges, I had a good support system. I had a good community around me, not only with my family and my brothers who always supported me. My mom and dad have always been there for me, never a doubt. And also with this community, they always taught me around with the college, like Dr. E, and also with the hospital, they taught me how to manage this successfully. I've also experienced, through these 15 years of having this disease, I've experienced the new technology and also the struggles of the disease that I'll be talking about today. I've also experienced the evolution of diabetes care, from finger pricks, of pricking my finger at least like 6 times a day, to a continuous glucose monitor that I'll be talking about later. And with this story, I've used it as motivation in my life. Like Dr. E said, I've been interested in science all my life, and I want to use this setback in my life as motivation for my future career. So, a little background on type 2 diabetes. So first of all, what is it? It is a chronic condition affecting the body's process of blood sugar. So your blood sugar is a thing that regulates throughout your body, and the gland pancreas is the thing that regulates it, and it regulates it by excreting insulin and glucagon. And in type 2 diabetes, that pancreas is not working anymore because of insulin resistance. And this differs from the disease I have, type 1 diabetes, because it is not autoimmune, meaning that the body does not attack itself. This disease affects 37 million Americans and also 451 million people worldwide. And a little bit about the risk factors. You can see the risk factors and symptoms of type 1 at the top, but the ones for type 2 that I'll be talking about are the genetics. You can inherit this disease if you have people in your family with this. Also age. As you get older, you're more prone to it with your inactivity. And also ethnicity. 47% are minority, so 13.6 Native Americans tend to have type 2, 12.9 in the Black community, and 11.1 in Hispanic. However, this makes up a greater relative percent. In the percent of Americans, there are only 3% of the population are Native Americans, and in that 3%, 13.6 are living with type 2 diabetes, so that's a great percent. Also, obesity and inactivity are risk factors as well. So a little bit about the pathophysiology of type 2 diabetes. Type 2 diabetes results, like I said before, the insulin resistance and eventual pancreatic destruction of beta cells. And with that, it chronically causes high blood glucose, which will eventually damage their organs. With that pancreas not working, the insulin will not be excreted and the blood sugar will become too high. And often in the early stages of getting this disease, it is often asymptomatic, so it is hard to catch. And one of the dangers of this disease is hypoglycemia and hyperglycemia. These things are when your blood sugar is too low in hypo and too high in hyper. With managing this, diabetics are trying to balance their blood sugar in a sense of making sure it's not too high or too low. Doctors tend to treat and want hyperglycemia because they would rather be too high than too low, because when you're having hypoglycemia, that would cause you to have a seizure and pass out and die in a sense. And hyperglycemia just causes the long-term complications at the bottom of the page of heart disease, kidney failure, and neuropathy. and eventual amputation of limbs. So a little bit about the evolution of diabetic treatment. So historically, in the early treatment, you have, for treatment, it would be diet and insulin. I know when I was diagnosed in 2009, I would have to give insulin via syringe, and we've come a long way over the years. I have used pens, which automatically, that's at the top of the page, and you can see that it has a certain amount, and you can set how much insulin you need. And now there are pumps in modern medicine. In type 2 diabetes, there's now oral medications. The most common is metformin or GLP-1 receptor agonists like Ozempic, and also SGLT2 inhibitors. In the future, researchers and doctors are predicting personalized medicine, and also with AI, more driven glucose prediction, so you can catch those rapid increases or decreases beforehand, so you don't have emergency room visits, and also it personalizes it with a certain individual. And hopefully with all this future technology that we can get closer to a cure for these diseases. So with treatment, in this diabetic treatment, there are two arms in a sense. One is measuring blood sugar, so knowing what your blood sugar is, that's very important because of the fluctuation, it's most important to know what your blood sugar is at the time. This would be a continuous glucose monitor or the finger pricks that I mentioned earlier. And also the other arm is maintaining blood sugar. This would be insulin or oral medication. This would be treating the highs of those blood sugar or even the lows with making sure that you're getting a balanced blood sugar level. However, access to these new treatments aren't equitable because many people can't afford the cutting-edge therapies, and I'll be talking about that in my next slide about the cost of diabetic treatment. So according to ADA, the average cost of managing diabetes is around $16,750 per year, and these costs include around the medication, insulin, devices, and doctor's visits. This makes it really hard for individuals managing this disease, and also some patients tend to skip meds due to the cost, which eventually will worsen their health. This is one of the biggest problems facing diabetes today, is that many people are not able to afford these medications that they need. These aren't things that you can skip. These are essential for you to live. And when they aren't paying for these medications, or they're getting off-brand, this will worsen their health. And affordability is the major barrier and is tied to the socioeconomic status and insulin coverage. So the educational impact of a history of patients for the social determinants would be if you have a lower educational attainment, is also linked with a higher result of type 2 diabetes. This tends to be because of the less access of health education in schools, which leads to poor disease management. In school, I know for me at least, when I was learning about science, or even in college learning about science, I would learn more about myself, and I would practice that in my life as well. School and based community educational programs also improve the outcomes, like I was talking about before. Also having that support around you, like for example, Dr. E always being there for me and teaching me about my disease, and also giving me tips and that. Things like that really helps me understand and treat my disease better. Also just understanding nutrition, exercise, and the medication also empowers the patients. Obviously, knowing what you are doing would help the problem that you're facing. Knowing what you're eating, putting in your body, also doing what you're doing on a day-to-day basis, how often you need to exercise, and the medication that you're using helps you in the long run. And then lastly, responsibility is a teamwork routine between patient, family, and doctors. I know for me, at the start, when I was 7, I was like, this is gonna be something I could deal with for the rest of my life. But I felt like my doctors really introduced the problem well to me and described it, and my family around me really supported me through all these struggles that I'm facing, and also my friends and community. I'm beyond thankful for them, and I wouldn't be here without them. So the social determinants impact, type 2 diabetes is higher in the Native American, Black, Hispanic, and Native American populations. This is due to unequal access to care, food deserts, and systemic racism. In these food deserts, this means that people in these communities are not close or are not able to afford or be able to access healthy food options. So they tend to go towards an unhealthy food option or choose a different option that isn't what is in their best interest. For example, in Black adults, they're 60% more likely to be diagnosed than white individuals because of these. And with these disparities, they are somewhat genetic. Like I talked about before, it is a risk factor that it is genetic, but usually these problems stem from systemic inequalities. So I'll be talking about the impact of CGMs. These are continuous glucose monitors, and I feel like they are a game changer. Like I said before, I used to prick my finger every day. I would have to log. I would have to set a certain time to prick my finger, which isn't really comfortable, putting a needle in your finger every day. And 4 years ago, I was introduced by my mom to this device called a continuous glucose monitor. And these provide a real-time glucose tracking, and they better control your blood sugar level, and it shows you a 24-hour time frame of what your blood sugar is. This also improves the outcome and also reduces the emergency room visits. It does this by showing the graph, like I said, on this screen here. It shows like a target range of where your blood sugar should be, and it also alerts you on your phone or a device when your blood sugar is being too high or too low. A tool that I like to really use is that there's a Dexcom share on it, so you can share it with those who you want to see it, so they can also be alerted as well. I share this with my parents and my athletic trainer and friends, just in case I get too high or too low, because when they're by me and like say I fall asleep and I get too low, it's nice that they can also keep care of me as well. And if I'm playing on the baseball field, my athletic trainer knows I'm okay as well. The installation and process of getting it on are, I'd say, easy to learn. It is difficult at first. You are installing it, a little sensor into your body, but it is the size of an eyelash, so it's not too bad. There's a little sticky part, and you just inject it into you, and then it connects via Bluetooth onto your phone. The barriers, however, for these CGMs are that they are high cost, and with limited insurance coverage, it's hard to get, and you have to have a little bit of digital literacy to understand it. But like I said before, these are a game changer, but they are not widely accessible, especially in low-income patients. And that is why I participated in this research study, and is why I used this as my project. And my proposed research questions were: how do socioeconomic, environmental, and technological factors influence the management of type 2 diabetes mellitus in diverse populations? And also, what is the role of these CGMs play in improving patient outcomes, particularly in rural and underserved communities? So my method of research while doing this was I was a part of a funded grant by the University of Nebraska Medical Center. I was approached this by Dr. E, who got me in contact with an endocrinologist named Leslie Island. She was really enthusiastic about this project. She's been wanting to do it for the last 2 years, and it is evaluating these CGMs, specifically the Dexcom G7, the most popular one, and its effectiveness in rural individuals with type 2 diabetes. We decided to choose to do this in Wayne at Wayne Family Medicine, and I would work remotely from here, and this is really great because being a student athlete in baseball, they worked with my time, and I was able to do work and play baseball at the same time. And the overall goal for this project was to improve glucose control and prescriptions in rural care at this Wayne Family Medicine. So my job title was Clinical Research Associate. It sounds fancy, but it's not that. It's really not that deep. I would use a computer. I would be given a list of diabetics in the area or that are in practice in the area. I would call those individuals and ask them if they were interested in participating in the study. If they said yes, I would schedule a time at Wayne Family Medicine to present them into the project, also give them a survey for baseline information, and then I would give them a 90-day supply, which is 3 months, of these CGMs funded by Dexcom, which is really nice of them. We would give it to them for free, just so they can understand and practice this technology. Our data was measured by a behavioral survey by UNMC that the patients took at their baseline visit, like I said before. We got these baseline visits and all this information so we could see the differences of the patients that we had and see if there's contributing factors between the diabetics. And we're also partnering with rural primary care providers. The primary care providers at Wayne Family Medicine were great, and they're very enthusiastic about this project. It was kind of unknown at the time, especially in Wayne, I'd say. People are scared of new technology, I'd say, around here. And the people, at least that I've consented, said that they've heard it in infomercials and saw it around town, but they just never pulled the trigger with going about and getting them. So they use this as an opportunity to get them. And these primary care providers are recruiting and helping those patients understand that these are really helpful. And the research team role, I feel like we've really hit home of the study design, participant enrollment, and follow-up and data analysis. I feel like this is the primary thing that we are going with this grant, is following up with them, making sure that they're safe and that they're really enjoying this experience, and also making sure that this is not only helping them with their emotional stress, but also with their overall health. So a little bit of baseline data summary. The average patient A1C level prior to using this, like I said, I got the baseline information. I haven't gone forth with this whole year-long study yet, but the baseline A1C level was 7.9%. It is recommended, this is a little high, the recommended A1C level is around 6, even being a diabetic or below 6. Even being a diabetic for 15 years, this is really hard to get to that goal. I'd say the best A1C level that I've had in 15 years was about 6.1, and I'd say that was the lowest I've gotten. So it's really hard to manage, I'd say. So I feel for these patients as well. As for gender, we have 5 individuals that are males and 3 that are females. And then with their education, 75% obtained a bachelor's degree and 25% obtained a graduate degree. And I think the data diagnosis, most were diagnosed in the past 2 to 3 years, I'd say, and there were 2 individuals that have been living for 5+ years. With those that have been diagnosed from 2 to 3 years, I can understand why they want to use this as an opportunity to attack this problem, because they want to overall help their health right away. As for the people, the 2 that had 5+ years, they said when they were talking with me that this is something that they've been looking for a long time, and they're glad that they have this opportunity. For the annual income of these individuals, it ranged from below $15,000 all the way up to $149,999, with that average being around $82,499. This is a statistic because, like I was talking about the cost of treatment, it is difficult sometimes to afford this, and we look into these after post, and we'll follow up with them and make sure that they're able to at least understand or give them a plan when they're done with this project. So the results of this research study, as from the demographics and background standpoint, we have 8 participants from when we started. Like I said, it's relatively new. The age range was from 48 to 79, with that mean range being 62. 87.5 were non-Hispanic white, and 1 was Latino Hispanic. And most had some college degrees, and 25 had a graduate degree, like I said. And I talked about the household income. As for the social struggles, 50+ reported moderate to severe emotional stress, and this is because of issues of burnout, frustration, and reduced food freedom impacting relationships. I know when I was first diagnosed, this was a big thing. I couldn't eat chips and cookies as much as I could anymore, and this is a big thing, and I could feel for those patients, and I could see why they could be burned out a little bit, because every time, a story that I like to tell is that I would go up to friends or brothers, that would be picking on me a little bit, and I'd say, imagine sometimes if you eat, every time you had to do that, you had to poke yourself. So it just puts that into perspective, and I feel like it really causes the burnout and frustration. As for the diabetes treatment and behavior, for medications, they usually range from one person using one oral medication to a person using 10 plus, including insulin, to use CGMs before briefly, so they had a higher confidence in self-monitoring. As for the others that weren't confident, I would educate them. Me or the nurses at Wayne Family Medicine would educate them on it so then they could have that confidence as well. And the common behaviors for these patients were having blood sugar checks, meal planning, and moderate physical activity. This was actually really exciting to see when I was consenting individuals. They come with a notebook and they would have what they ate that day, what time they checked their blood sugar. So it shows that they're really caring about their health and want to be better. As for the inside of the project, I feel like even with education and income, I feel like emotional burden is high, like what I was talking about. And I feel like patient experiences highlight the need for compassionate individualized care. I feel like this is a big thing with the project. I feel like this is giving not only information for us at UNMC, but also for the primary care providers at Wayne Family Medicine, so then they could use this to help those that are being diagnosed in the future. So a little about conclusion of what's next. So our hope with the study, obviously, is to increase prescriptions with these CGMs, and also just to get the patients more comfortable with the diabetic technology, have them understand that it is a teamwork thing, and that there are people in the community and around that want to help them, and we kind of just want them to want to improve their health, not to just lay back and feel defeated, but to attack this issue. And I feel like I and the people at UNMC really want this study to benefit greatly with their purchase from Dexcom. They are spending money on these Dexcoms and giving them for free, and so they're trying to make sure that this really benefits the community and makes this project worthwhile. And I think so far it is definitely beneficial, because the people interested in this study are really excited and really fortunate that we are doing this. This study, like I said, will continue for the duration of the 2025 year with their 3, 6, 9, and 12-month visits. We will check in on them and get the data and see if they're improving their health. And after this, I will be passing the baton to a Wayne State Honor student, Sydney Eskrit, who will continue this research. I will best help her on this transition, but I'm sure she'll do a great job after it, and I know the people involved in the study are really excited to have her as well. And lastly, I'm really just thankful for everyone involved in the study. I'm thankful for Dr. E for introducing it for me and helping me through this process. The people at UNMC with Leslie and everyone involved, the nurses and the primary care providers at Wayne Family Medicine that have all made this process really great for me, and I'm just thankful for everyone. That's it.